Hi, good day. This is a continuation of our discussion for the care of clients with disturbances in locomotion. Our focus in this discussion will be your inflammatory disorders. Let's start by talking about gout. The image on the screen would show an X-ray image of a patient with gouty arthritis. Class, notice that there are white deposits on the big toe. Note that it is the big toe that is usually affected in gouty arthritis. These white deposits are actually signaling inflammation, and then other than that, these are already your crystal deposits of your uric acid that we oftentimes refer to as tophi. So these are already your tophi deposits. Okay? Now, what is gout? So when I talk about gout, it is usually referred to as acute inflammatory arthritis. Why acute? Okay, the causes of the attack are usually acute, meaning it might happen hours or weeks ago, wherein the patient might have had an increased intake of uric acid. So, this is triggered by urate crystallization within the joints. Take note of the words urate crystallization within the joints. And this develops in response to excess of the uric acid in the body. So you have these problems: increase of uric acid inside the body, which leads to urate crystallization, and then later on acute inflammatory arthritis. Now, this PowerPoint would show us, or this picture would show us that an acute gouty arthritis would usually affect the distal interphalangeal joints. So the sites affected are your distal interphalangeal. So when I say distal, the farther end on the interphalangeal between your phalanges. What are the risk factors? Male gender is usually affected. And then it is the old age which is usually encountering problems with gouty arthritis. Those who are hypertensive and those who are obese would have a higher tendency of having your uric acid formation. Okay? Patients with metabolic syndrome would also have high risk. So when I say about metabolic syndrome, meaning there is an imbalance in the cholesterol and then their sugar may be marginally high already. Okay, so as for patient with type 2 diabetes. So in type 2 diabetes, it is usually associated with the poor perfusion going towards the lower extremities. The tendency for the crystals to develop. Okay, chronic kidney disease. Your chronic kidney disease is both a risk factor and a sequelae also of your gouty arthritis. It is considered as a risk factor because if your patient would have chronic kidney disease, the kidney will not be able to excrete your uric acid. Medications. So you have your diuretics and then you have your aspirin. Diuretics and aspirin are medications that are known to increase your blood uric acid. Okay, meaning they prevent the elimination or they prevent the excretion also of your uric acid. So for that reason, they are usually not given for a patient with uric acid problems. Now, let's recall the pathophysiology of your gouty arthritis. What is the problem of a patient with gouty arthritis? So class, sex. Okay, male, as I've mentioned, is more affected compared to female. And then age of greater than 40. Diet. Okay, their favorite diet. Okay, meat, seafood. Okay, usually class even your mongo beans, which would have high uric acid levels. Then you have your alcohol, sugar containing drinks, and then your obesity, and then you have your diuretics and aspirin. All of these factors combined would lead to the overproduction or undersecretion of your uric acid. So when I talk about uric acid, note that your uric acid is byproduct of metabolism of the food that we are taking. So if you are taking a lot of food, which are later on converted to uric acid, that would increase obviously your blood uric acid levels. Under secretion, in conditions such as, for example, your chronic kidney disease, your patient would not be able to excrete your uric acid. And because of that, there will be crystallization of your urates. Okay? Urates are byproduct or formed, with the clumping of your uric acid. These urates would crystallize and then later on would be deposited in the subcutaneous tissues and would even be deposited first on the interphalangeal joint. With the deposition of your urates in the interphalangeal joint, the inflammation would ensue. This is the reason why a patient with gouty arthritis would have signs of inflammation. Now, the urate deposits in the subcutaneous tissues are oftentimes referred to as tophi. Okay, take note, subcutaneous tissue. That's why in severe cases of gouty arthritis, you will see patient with white chalky discharges even on their auricle or pinna. Okay, yeah, the auricle and pinna of your ears. Okay, that's where the deposits of your uric acid may arise. Okay, and then later on, in the long run, you will have your urate kidney stones. So this is what I've been talking about, that your uric acid, okay, your increase of uric acid is also a sequelae or consequence of your gouty arthritis. Prolonged increase of your uric acid levels would lead to formation of your urate kidney stones. Once these kidney stones are present inside the kidney, it may initiate the process of your intrarenal kidney failure. Okay, so you will have signs and symptoms of your kidney failure, which would include fluid deposits, okay, or edema. Now, one characteristic of a patient with gout is that the pain would be abrupt onset and usually be at night. And the pain is usually found on the first metatarso-pharyngeal joint. Okay, correct, metatarso-pharyngeal joint. Okay, or your great toe. That's usually the first victim. Okay, so for us to know what is high and low for uric acid, of course, you need to familiarize that for the men, that would be 3.5 to 7 milligram per deciliter, whereas for female, it would be playing around 2.8 to 6.8 milligram per deciliter. Okay, there are several drugs of choice. Later on, we'll talk about the other drugs. For the meantime, just remember that your allopurinol is the drug of choice that would lower the urate levels. Okay, again, allopurinol is the drug of choice that would lower your urate levels. Other than that, your patient would have the recommendation to take low purine diet. Okay, so when we talk about low purine diet, it is not advisable for them to take internal organs. It's not advisable for them to take meat products. Okay, they need to be decreased. Okay, they need to be decreased. And then take note that they need to have 2 liters of water daily. And then they are usually advised to have your sodium bicarbonate and potassium citrate. Okay, so take note, you are dealing with uric acid. Okay, acid is the word there. Okay, so an acidic state will be common in the bloodstream. With that, you need something to combat the acidic effect, and that would be in the form of your sodium bicarbonate. Okay, so recall that your sodium bicarbonate is the drug of choice for acidosis. Then you have your potassium citrate. Okay, your potassium citrate here will be able to prevent the deposits of your kidney stones or urate kidney stones, hence reducing the risk of kidney failure for your patient. Okay, so take note of that. So oftentimes, the patient would also experience synovial or fluid membrane problems or crystal deposits. Also, the cartilage would have inflammation, and then there will be tissue damage. So that's why the main sign and symptom experience of a patient with gouty arthritis is no other than pain. Okay, it's no other than pain. Now, there are 4 stages for your gouty arthritis. The first stage is asymptomatic hyperuricemia. What do I mean by asymptomatic hyperuricemia? As the term would imply, asymptomatic. Okay, the blood uric acid levels are already increased. However, the patient is not having any manifestation. The second, acute gouty arthritis. So when I say acute gouty arthritis, that will be the time wherein the patient would have a flare. Okay, the patient's usually one joint is affected, and then it is unexpected at night. Okay, and then it would last for hours, up to days, even 10 days. And then there will be an asymptomatic interval. Okay, an asymptomatic interval wherein the patient is not feeling anything weird or painful inside his body, but instead the patient would just feel that as if its gouty arthritis was already gone. Okay, then your patient would have advanced gout. Okay, that advanced gout is characterized by urate pool expansion. So when I say urate pool expansion, there is already an increase in your urate crystallizations. Now, there will be deposits of your tophi, again, as I have mentioned, even in your ear, even on your ear, in your auricle, in your pinna. There will be joint stiffness. Okay, the stiffening there is related to inflammation. That's one. Second, it's also related to the deposits of your urate. Okay, that's also the same reason for your limited range of motion exercises. Okay, so the tendency is your patient would progress again from asymptomatic hyperuricemia going towards acute gouty arthritis, followed by asymptomatic intervals, followed by your advanced gout. Okay, so what can we see in the laboratory findings? You'll be seeing a patient with increased WBC and erythrocyte sedimentation rate, because these are indications already of inflammatory processes happening within your patient's body. Now, for the pain experienced by your patient, NSAIDs are given. Indomethacin is one of the drug of choice. Then you have your colchicine. So colchicine interrupts the cycle of your urate crystal deposition. Okay, look at this. Your allopurinol earlier was intended for a different action, but this time your colchicine would interrupt the cycle of urate crystal deposition. In other words, your colchicine will prevent the conversion of your uric acid to becoming urate. Okay, and with that, okay, you are saving your patient from the pain experience, because again, the pain is because of the deposits. Okay, the pain is because of the deposits on the joint. Okay, so that's the purpose of your colchicine. Now, try to ask yourself, what is the difference in the functioning of your allopurinol and colchicine? And between the two, which can be used for an acute attack, okay, or acute gouty arthritis attack. Try to pause the presentation and try to figure out yourself. Okay, so what are the manifestations? Okay, these are the manifestations that I've already mentioned. And then the complications, you have kidney disease, and your kidney diseases may be in the form of your nephrolithiasis or your kidney stones, and this time we are saying urate stones, and then it may also lead to acute renal failure. A sudden increase in the amount of uric acid in the bloodstream could possibly damage also the kidney, okay, resulting to acute renal failure. You need to watch out for acute renal failure because you don't want that your patient with gouty arthritis would also have signs and symptoms of edema and fluid volume excess, because it will be difficult for us to manage once your patient would have the concurrence of your acute renal failure along with your gouty arthritis. So what are the diagnoses? Okay, the diagnostic tests being used. Okay, you'd expect your uric acid to be elevated. Of course, that's our main problem. The WBC count is also expected to be elevated. Okay, your eosinophil sedimentation rate, because we're talking about inflammatory processes, is also expected to be increased. Your serum creatinine and 24-hour urine specimen collection are all intended to evaluate the study. Okay, are all intended to evaluate or study the presence of your renal problem secondary to gout. Okay, in other words, the principle there is that early detection would be better than cure. Okay, that's why your patient would have serum creatinine and 24-hour urine specimen collection. What then is the focus of medical management for this patient with acute gouty arthritis? Medications class. During an acute attack, your NSAIDs would be able to help. Okay, so as your colchicine, corticosteroids in more severe cases, so that the inflammatory process would be halted. Okay, now let's talk about anti-inflammatory gout drug. One is your colchicine. If you would look at your pharmacology textbook, it would remind you that colchicine is an anti-inflammatory gout drug. Okay, it is able to inhibit the migration of leukocytes to the inflamed site, alleviating the symptoms of gout. Okay, but take note, your colchicine is not capable of decreasing the inflammation that occurs with other problems or disorders. Okay, and you need to watch out for severe kidney, heart, and GI problem for your patients who will be undergoing colchicine therapy. Okay, the second classification of medication perhaps is your uric acid biosynthesis inhibitor. Okay, again, the term is uric acid biosynthesis inhibitor. One example of which is your allopurinol. Okay, allopurinol is common. Now, it would inhibit the final step of uric acid biosynthesis, and hence the effect would be to lower down your serum uric acid levels. Okay, it is used also classed as a prophylaxis for gout, and it is a drug of choice for patients with tophaceous gout. Now, you have your uricosurics also. Okay, so class for your uricosurics, one example is your probenecid. Okay, probenecid. Now, your probenecid would increase the rate of uric acid excretion and block the reabsorption of your uric acid. Okay, so that would be the three medications that are commonly used for the management of your gouty arthritis. Again, the first one will be your anti-inflammatory gout drug, which will be your colchicine. The second one is your uric acid biosynthesis inhibitor, which will be your allopurinol. And then the next one is your uricosurics, which is your probenecid. Okay? Now, complementary and alternative medicines are geared toward nutrition, herbal supplementation, and then the rest of your involved joints. Okay, so when you're talking about pain among patients with musculoskeletal problems, okay, resting the involved joints will be already one of your prime concerns. So, our main nursing concern for this patient class is referred to as acute pain. Okay, that's the main nursing diagnosis that you will be seeing on this patient. Okay, acute pain again because of the deposits. Okay, now you just need to educate your patient, of course, on pain management strategies starting from non-pharmacologic going towards pharmacologic, and then continuity of care must be considered, and then give them the rationale why they might need to take colchicine along with aripiprazole. Okay, why does these two medication cannot act and just help one another? Why does she need it to take on time? Okay, or why does she need to take two of the tablets at a time? So that's something that you can explain to them. Then, rationale for and the use of prescribed medications and the importance of high intake of fluid each day, and to avoid your alcohol also. Our next discussion will be on the degenerative disorder, osteoarthritis. Dear students, thank you for your attention.